Well, good morning again. So the topic, this is kind of a workshop, and sometimes we set this up with pencil and paper, but we don't really have the desks and things, so you get off easy today. We're just going to do a lecture. And what's the point of this lecture? It's the practicalities of how you order the nail. Unlike your trauma nails where you have everything on the shelf and you just measure and say, give me a 34 or a 36 or a 38, here you have to order ahead of time. And so you have to sit down and do the planning of each case to decide what type of nail you want, what size of nail, what length of nail, where your osteotomy is going to be. All this needs to be planned out ahead of time. So it's a little bit different than what you're used to in the trauma world for IM nailing. So what we have to think about is the type of nail, the diameter, the length, and the level of our osteotomy, because size does matter. So in general, at least in the US, I don't know, in Israel, we have to order these nails 2 weeks in advance because they're coming from California, and you want to make sure you have what you want. So at least 2 weeks before the surgery, you have to talk to your representative. And then when we decide on what size nail, I strongly recommend that you order 2 nails, one to insert and one as a backup. What happens if you drop it on the floor? You can't pick it up and put it in the sterilizer, not allowed. So you have to have 2 of every size. So if you're ordering 2 different sizes, you need 4 nails. 3 different sizes, 6 nails. Sometimes I have 8 or 10 nails. So I often am not sure in the exact size that I want, and I'll have the representative bring 2 different size nails, a 245 and a 280, so I can have whatever is going to fit best at the time of surgery. But most importantly, you should plan ahead of time based on AP and lateral films with a mag marker. And many times people send me an x-ray. They say, Dr. Herzenberg, what do you think about this case? And they send me an AP lateral femur. I say, yeah, it might be a good case, but if you want to order the nail, you need a magnification marker because you have to know exactly what the different lengths are and diameters. So always when you're planning these cases, please use some type of magnification system. In the femoral nails, there's 2 different main types available, antegrade and retrograde. But within each family, the antegrade family and the retrograde family, you have straight nails and bent nails. So the antegrade nail could be a trochanteric entry or a piriformis entry. Retrograde is available as a bent nail. I used to use those, but now I almost exclusively use the straight nail. I almost never put in a bent nail retrograde. Although sometimes if you want to extend the femur, you can put it in reverse, so there may be some uses. In general, antegrade is easier to put in than retrograde, and I think in my experience, probably 90% of my cases are femur antegrade, not femur retrograde. And it's much easier to put in the piriformis nail than a trochanteric nail. This is different than the trauma nails you're using. The trauma nails have a different design, they have a bend to them. These nails are rigid and straight. So to put it in through a trochanteric approach is a little bit more challenging. Sometimes you have no choice, in children, for example, but if it's possible, I prefer to use a piriformis entry. Retrograde has its indications. You may have a blocked proximal canal by hardware or previous surgeries, or if you have a distal deformity that you want to correct at the same time. But also remember that retrograde insertion will disturb the knee. So you must take that into account, that your rehabilitation and physical therapy will be easier if you go antegrade than retrograde. And retrograde is contraindicated in children. They have a growth plate. We don't want to violate the growth plate. Now, some people are doing some experimental work where they're putting nails across pediatric growth plates, but right now I would say I wouldn't do it. And this is very important, but the piriformis entry is contraindicated in children. Children means anyone with an open growth plate. It could be 15 years old, still a child. And why? Because there's a risk of avascular necrosis of the femoral head. So in children, we always use a trochanteric entry. All right, now we look at the femur, we have to consider the specific anatomy. And I'll show you some examples of this. But we look at the length of the neck. In a short neck, we don't want to go piriformis. Is the capital femoral epiphysis fused or not? Because if it's not, we don't want to go piriformis. Is there an AP deformity? And really more importantly in the femur, is there a sagittal plane deformity? It's extremely important to look at the sagittal x-ray and also look at the diameter of the bone and its narrowest point, which is usually subtrochanteric, because the narrowest point is going to determine what size nail you use. So let's just look at a case. This is a lady who had a congenital femoral deficiency. I previously lengthened her. She has still now, as an adult, she has 6 centimeters leg length discrepancy. She's finally decided after 10 years it's time to lengthen again. But now we have the new technology. So how should we put in the nail? Should we use a trochanteric entry? She's an adult, so we could go piriformis. What do you think? Here's a close-up of her x-ray. Piriformis, how many say piriformis? How many say troch? Okay, so why troch? So if I did a piriformis, the nail would be really in the head. You know, it would be at the base of the neck, and it might risk a fracture. So she has a very short neck. So based on the short neck, I say, I'd like to go piriformis. I prefer piriformis, but I'm sorry, we have to go troch because she has a short neck. Now sometimes if you rotate the film with the C-arm, you can rotate the leg. What looks like a short neck is actually not so short. So if we're doing her left side, I would order piriformis. But for her right side, I would order a trochanteric entry nail. Okay. And this is the case. We did a troch entry. Actually ended up using a retrograde femoral nail. We didn't have the piriformis, but the troch entry. But this is a 10-degree bend in the nail. So we entered through the trochanter. And that way we preserved her neck. Okay, this case. Are we going to go antegrade or retrograde? Or, I'm sorry, forget the deformity. Are we going to go piriformis or troch? Troch. Why troch? Because it's a kid and we're concerned about the femoral blood supply. So whenever you're dealing with skeletally immature patients, the piriformis is dangerous. You run the risk of injuring the circumflex femoral vessels, and that would create AVN. So you must go piriformis. I'm sorry, trochanteric. And this is the case. We put in a 10-degree bend troch entry nail. And when we put these in, we're very careful. I have a talk about it tomorrow, but we're very, very careful not to get anywhere near the blood supply. In this case, we handled the distal deformity with guided growth. Okay, 2 centimeter LLD in an adult patient, skeletally matured. We go troch or piriformis. How many people want to go trochanteric entry? Piriformis? Anybody? Okay, I agree. So this is normal anatomy. We can go piriformis. Why piriformis? Because a lot of trauma surgeons in the community prefer trochanteric entry because in the community you don't have a lot of help, residents and things, so it's easier to go troch entry. But the piriformis is easier to put this nail in because it's a straight nail going through a straight canal. If you try to put it in from the side, it gets stuck sometimes on the medial cortex. So whenever possible, I prefer piriformis, and this is the case. We used a piriformis entry. Okay, this is an adult who has a small discrepancy, 3 centimeters, and also there's valgus of the distal femur. So there's the deformity. This is the deformity analysis. There's about a 5 or 6 degree valgus deformity. So antegrade or retrograde? Yeah, for a small lengthening like this, 3 centimeters, I think I'm very comfortable going retrograde. If it's 5 or 6 centimeters, maybe I'm a little bit more concerned about the effect on the knee. But for 3 centimeters, I'm okay with that. So retrograde is what we order here. This is the case after we've corrected it with the blocking screws, just like you saw. Okay, this is actually the same case as the first one I showed you. But now I'm showing you the sagittal plane deformity. So antegrade or retrograde? And do I need to worry about any bowing here? Well, if you do the analysis, there's actually 2 bows. There's a proximal bow subtrochanteric, like most people have, And there's also this distal bow that's related to the prior lengthening that she had. So who wants to go antegrade? Who wants to go retrograde? Okay. Well, I chose antegrade. I showed you the case already. And what you have to do when you're planning the antegrade is see where this apex of the bow is. That tells you where your osteotomy is going to be. Based on the osteotomy, I'll show you a system to determine where what length nail to order. But in this case, my concern, this is what we did. So I accepted this because she didn't mind the knee. She was happy with the knee. And it's a straight nail. It's not going to go beyond this bend. So that's the longest possible nail that we can use. So why didn't I do a distal? Here's my concern. If I plan this out with a distal correction, what does that do to the knee? I think what's happened over the years, she's developed laxity of the posterior capsule to accommodate this deformity. And so if I were to correct this with a retrograde nail, I would expose this laxity. And I think she may not be happy with this recurvatum knee. So based on this, I decided not to go retrograde, but indeed to go antegrade. But you have to see that there is a bow in the front, in the top, so you have to take into account that bow and you're doing your planning. Okay. Now, when you look at these nails are very, fine, delicate instruments. It's like a little Swiss watch inside the nail. And there's a male portion and a female portion. And as with any mechanical construct where you have two different sizes coming together, there's a stress riser. And that's a weak zone in the nail. And that's if the nail is going to break, it's probably going to break somewhere in that weak zone where the thin male portion is, or where the male-female junction comes together. So when we plan out our surgeries, we want to make sure that that weak zone of the nail is not in a high-stress area. What's a high-stress area? Where the gap is, where the distraction is. So let's talk about that. Also, we need to talk about the fact that these nails have no curvature. There may be a Herzog bend in the top, 10 degrees, but the nail itself is ramrod straight, completely straight. Whereas the normal femur is not straight. The normal femur has an average radius of curvature of 1.2 meters. It's a circle whose radius is 1.2 meters. And so when you design, if you're designing a nail for a femur fracture, you're going to design a nail that has a slight curve in it to accommodate this radius of curvature. But when you're designing a lengthening nail, that's not possible. You can't have a lengthening nail that will lengthen over a curve. Has to be a straight piece of machinery, at least with current technology. So the nails that we're used to in trauma have a curve. And here's some examples. This is from the AP view. It's a trauma nail, but from the side, you can see there's a slight curvature. And so it can enter the canal very easily. But if you try to jam a straight nail down this curved bone, it can be very difficult. So we have a couple of strategies for doing that. So, different nails have different radiuses. The Gamma 3 has a 2-meter radius. The Striker T2 has a 1.5 to 3, depending on the, but the precise nail, the one that we're using, has no radius. It's an absolutely straight nail. So how do you fit a square peg into a round hole? And so one of the solutions is you unbend the femur. So you make your osteotomy at the apex of the bend. Okay, we'll get back to that. Tibial nails come in one size only, or one shape. It's a 10-degree bend. But when you look at the tibia, you have to consider, is there an AP or lateral deformity? What is the outside diameter of the bone, the narrowest point on the AP and lateral? So here's an example of an Olier patient, and she's had prior surgery, but she has a 2-centimeter leg length discrepancy, and there's this funny anatomy here in a distal tibia. So when we're planning this case, we have to plan a relatively short nail because it's not going to pass that deformity. So this is an example of a case where you must plan out ahead of time, measure the shortest nail length that you can use, and order that nail size. This is a post-traumatic tibia that's had a lot of surgery down here and has sclerotic canal. So when we look at her x-ray, she also is going to need a short nail because you can't get a nail that's going to pass through this sclerosis. So you have to look at your x-ray and plan it out ahead of time and order these short-sized nails so that you can complete the case. And you notice the use of, a liberal use here of blocking screws. These nails are available currently in 3 sizes, 8 millimeter, 10 millimeter, and 12 millimeter, or more specifically 8.5, 10.7, and 12.5. Which one should you use? Well, my friend Bill Terrell has a saying, you're never wrong with strong. So always go, bigger is better, provided the bone can fit it. I like to use the 10.7. I think that's plenty strong, but in a big person, I'll use a 12.5. And on some small children, you have no choice. You have to use the 8.5. But the 8.5 is very flexible, and so it's not ideal. Now, another strategy for putting these nails into a curved bone is to over-ream. So normally in a trauma nail, you ream 1 millimeter over, maybe 1.5. In these nails, I recommend you ream 2 millimeters at least. And sometimes if it's tight when you put it in, I'll take it out and ream 2.5 or even 3 millimeters bigger. But you don't want to really use a lot of force and bang really hard on these nails, because remember, there's a Swiss watch inside. And you wouldn't take your Swiss watch and bang on it with a hammer. So the same thing with these nails. If it hits a solid point and you're banging, you can damage the nail. Now, when you're deciding how much you have to ream, you also want to make sure you leave a certain amount of cortex available. So here's a cross-sectional picture of a bone, and the bone measures on X-ray 19 millimeters wide. I want to use a 10.7 nail. I'm going to ream it to 12.5, 2 millimeters bigger. So if I do that, how much is left? Well, you can do the math. 19 take away 12.5 leaves you 7 millimeters. So you're going to have about 3.25 millimeters on either side when you're finished. And so, what's the minimum? I mean, you'll see some X-rays that your speakers are showing you that have a pretty big nail and reamed out the canal quite a bit, but you have to be careful not to ream it out too much. So this is my chart. For an 8.5 nail, I recommend, you're going to ream to 10.5. I recommend that the minimum outside diameter should be 17. For a 10.7, the minimum should be 19 millimeters, and for a 12.5, the minimum OD, outside, and this is not the canal, but the outside diameter is 21 millimeters. There's also an issue of how strong the ERC is. That's the electronic remote controller. The smaller the nail, the smaller the magnet. The smaller the magnet, the harder it is for the outside controller to activate it. And with these small nails, you have to be within 3.5 centimeters. So if you have a thin leg, you can get within 3.5 centimeters. But with the big nail, you can be 7 centimeters away. So if you have a big person, like my leg is pretty big, I would prefer to put in a 12.5 nail, because the ERC doesn't have to be so close. And don't forget also that however far the distance is, after surgery, it's even further, because there's swelling and some hemorrhage, and the leg gets bigger. Okay, osteotomy level. This is really critical. The osteotomy level has to be at the apex of the bow on the femur, and then you need to have sufficient nail distal to the osteotomy after the lengthening. So there's a rule that we've come up with. It's 3 centimeters to account for the male portion of the nail, plus the amount that you lengthen, plus another factor of 4 to 5 centimeters, and that determines the level of the osteotomy. Let me illustrate it with this case. So this is a 24.5 centimeter nail, pretty typical size nail for tibia, relatively short. And the yellow zone here is the danger zone. So where should the osteotomy be? How far from the tip of the nail? How far from the danger zone? So we go back 3 centimeters to accommodate the male end, and we're going to lengthen 5 centimeters, so we have to add another 5 centimeters. And then we want to have a certain factor beyond that. So I'm going to show you 3 examples of osteotomies. One done very distal, one in the middle, and one proximal. Which is best? Well, if I do the osteotomy distally, the weak zone is right in the high stress area. So that's bad. I don't recommend that. If we do the osteotomy in the middle of the tibia, our weak zone is still pretty close to this open area, this high stress area. So maybe not ideal. But if I do the osteotomy more proximal, then when we're finished with the lengthening, the weak zone of the nail is fairly far away from the high stress area. So when you're planning out the osteotomy, you have to take into consideration. So the formula that I use in my practice, I go back from the tip of the nail 3 centimeters plus the amount of anticipated lengthening plus an added factor, which is 4 to 6 centimeters, let's say 5. So in a case like this, if this is the length of nail I've selected, the osteotomy has to be 3 plus 5 for the lengthening plus another 4 or 5, so it'll be about 12 or 13 centimeters above. And that would be the closest I would want to get with the osteotomy. Now, there's an advantage to doing diaphyseal osteotomies in that you don't get deviation. So that's kind of nice. But this is what you would end up with in the end. So even after you've done all that, your weak zone is probably far enough away from the weak area here. Okay. If you make a bigger buffer zone, it's even further away. So here's, this is a case of a femoral deformity, or it's not a deformity, it's a normal femur, but on the lateral view there's a sagittal plane deformity, there's an apex anterior bow, and so when we do the osteotomy, we plan it at that level. We have to select a nail that's long enough that will be far enough away from that osteotomy. So when I'm planning the femur, I start with this sagittal plane view, and based on that, select the nail size. This is a retrograde issue, and here we're usually far enough away, but on the sagittal plane you have a bow, and so typically the nail has to end at that bow. So these are the selection of nail sizes and shapes that you have available, and the final thing you have to take into account is that the shorter nail sizes are only capable of lengthening 5 centimeters. The longer nail sizes from 245 and beyond are capable of lengthening 8 centimeters. So if your patient needs a 6 centimeter lengthening, you want to try to put in a minimum of a 245 nail, because the shorter ones are not going to be able to get you that amount of lengthening that you want. So that's just an introduction to how we plan out select the nail type, the diameter, the length, and the osteotomy level. And all this has to be done before you start your surgery, or weeks before you start your surgery, so you can order them ahead of time. Thank you very much.